Identifying polymorphisms in the dihydropyrimidine dehydrogenase genes are gaining importance as predators of fluoropyrimidine-associated toxicities. Fluoropyrimidines are one of the most widely used chemotherapy drugs against solid cancer, and millions of cancer patients are exposed annually to these drugs, which includes 5-fluorouracil and its oral prodrugs, capecitabine and tegafur. Some adverse drug reactions are a major clinical problem during chemotherapy treatment. Unfortunately, up to 30% of patients treated with fluoropyrimidines experience severe treatment-related toxicity, and almost 1% of these patients, this toxicity is lethal. So in patients with certain enzyme deficiencies that act on the fluoropyrimidine metabolism, however, the use of these chemotherapeutic agents can lead to life-threatening complications, including severe nausea, vomiting, diarrhea, and balloon depletion, extensive skin and mucositis changes, pancytopenia with the risk of bleeding and infections, but also cardiotoxicity and neurological abnormalities. The most important enzyme in fluoropyrimidine metabolism definitely is dihydropyrimidine dehydrogenase. So our article pointing out this theme and brings some data from Brazilian population. Well, genetic variants in the genes coding DPD are enzymes that can alter the metabolism of 5-FU and clinically significant predators of fluoropyrimidine toxicity. Variants in DPYD, the gene that encodes DPD, the dihydropyrimidine dehydrogenase, are gaining importance as predators of fluoropyrimidine-associated toxicity because the serum tests that detect them are increasingly available, and based on them, some dose adaptations now recommended by some guidelines. In 2020, the European Medicines Agency recommended preventive testing for DPYD variants before starting cancer treatment with fluoropyrimidines. Now, there are some possible methods to evaluate DPD function and verifying DPD activity. We can measure the DPD enzyme activity in peripheral blood mononuclear cells, a breath test, quantification of metabolites such as dihydrouracil plasma, and measuring the metabolism of a single dose of uracil. However, measuring DPD activity in advance on a routine basis is technically and logistically challenging, laborious, and expensive, and also lacks some worldwide validation. The DPD phenotype is assigned using an activity score based on the DPYD allele functionality and calculate as the sum of the two DPYD variants with the lowest variant activity value. There are 4 main variants: DPYD star2A, star13, haplotype B3, for example. And some difficulties in analyzing individual variants and determining the real clinical consequences are population difference, sampling effects, therapy-related heterogeneity, and heterogeneity in toxicity assessment. The frequency of the various DPYD variants and the associated phenotypes appears to vary significantly between ethnic groups. Considering all 4 main variants combined, up to 7% of the white population has a partial deficiency, and less than 2.2% has a complete deficiency on DPD enzyme. The allelic frequency of the 4 main variants according to our repository here in Brazil, which contains genomic variants identified by whole exome and whole genome sequenced from more than 1,000 related elderly healthy patients, we found that the variant that is more dangerous variant, the star2A, is less than 0.25%. And another variant, 557, is about 0.5%. Brazil is a large country with very ethnic differences. So north of our country, the Amazonian Amerindian population showed mineral allele frequencies of 1% of 0.28, 4 times higher than here in South Brazil. Also, our Black population present a frequency of 557 variant of 2.6%, 5 times higher than here in São Paulo. Well, considering only colorectal cancer here in Brazil, more than almost 2,000 patients would be at risk of severe toxicity with the use of fluoropyrimidines. So some guidelines address this topic. In summary, they suggest that individuals with genes activity score of 0 or 0.5 are recommended to avoid fluoropyrimidines. When the activity score is 1 or 1.5, they recommend initiate therapy with at least 50% of the standard dose, or it means a reduced dose of flavoracil or capecitabine. An activity score of 2 that is normal activity, there is no recommendation for dose adjustment. Well, some studies suggest that prospective test would result in cost savings. The hospital admission for severe chemotherapy-related toxicity is significantly more expensive than prospective testing DPYD for patients starting fluoropyrimidine chemotherapy. Of course, that we need comprehensive genetic testing of DPYD is needed in future studies involving the use of fluoropyrimidines. The recommendation of chemotherapy and dose adjustment guided by the presence of DPYD polymorphisms can become mandatory in the near future, with the potential number of lives that can be saved, complications that can be avoided, and costs that can be reduced worldwide. We must discuss with patients the rarity of these variants, but also their implications, considering costs of pharmacogenetic tests. Despite the recognized relevance of the genomic tests, treatment with fluoropyrimidines should not be substantially modified until definitive recommendation based on the medical oncology community is generated, taking into account all aspects of this molecular approach, including access, costs, and accuracy. Yes, it's cost effective. There were Irish studies that proved that prospective testing is much cheaper than paying the cost of hospital admission due to toxicity related to chemotherapy with fluoropyrimidines. And now we have some new data from the United States that the insurance may cover this test because it's cost saving also. Yes, we have several answers to question to answer. Well, one of them is that we don't exactly have sure if a patient presents a DPYD variant, this variant that will really be clinically significant. It means the patient may harbor a variant that is not clinically significant. So we could give him a lower dose of fluoropyrimidines that he really needs, and we don't know how to answer yet. So the penetrance of these variants are not 100%. We must comprehensive better which patients and which variants that is an even higher risk for clinically relevant consequences. So identifying polymorphisms in the DPD genes is very important. There are some dose adjustments that might be needed for patients with some variants, and it can potentially improve treatment safety for a large number of patients, saving lives, avoiding complications, and reducing healthcare costs.